Welcome in the Interstitial Lung Disease Basic Understanding Part 1. We will continue Part 2 video of this. In this discussion we will try to understand about the ILD, basics of ILD, understanding disease from etiology, from definition to the pathology, and sometime CT and radiological finding also, and little bit of the management part. So let's start. ILD are heterogeneous collection of more than 100 distinct lung disorders that tend to be grouped together because they share clinical, radiographic and pathological features in common. And ILD is an umbrella term. Actually, ILD is not a single disease, it is an umbrella term that has many group of diseases actually. So ILD is not a single disease per se, it is an umbrella term given for a large group of diseases that have a similar characteristic to cause lung fibrosis. So all the diseases grouped under ILD cause some sort of fibrosis in their different course of timeline. Alright. So this is why ILD, we should know that it is not a single disease itself. The confusion arises is the term itself, because ILD is a confusing terminology. Why so? Because interstitium is not only involved in this disease. And the pathogenic sequence in actuality involves a series of inflammation and fibrosis that extends beyond the disrupting the interstitial bed, as the name implies, to changing the parenchyma, including alveoli, alveolar duct and bronchiole. So disease to start with the interstitium, but as the disease advances in due course of time at a different timeline in a different disease part with the etiology as well. So it involves the parenchyma also. So pulmonary parenchyma is also involved with variable stage and timeline of the disease. Due to this, sometimes it is also called diffuse parenchymal lung disease, and that is probably a better term rather than ILD. But yes, the disease usually starts with the interstitium. The site of initial injury or initial event or initial inflammation starts within the interstitium, but as the disease progresses on with the time, it also involves the pulmonary parenchyma. So the first step in the evaluation of ILD begins with the fundamental knowledge of the anatomy of the pulmonary interstitium. So we should understand that this disease involves which part of lung. For example, like bronchial asthma, your COPD, these are diseases of the bronchial or the airways. Likewise, we can say that this disease is the disease of the interstitium. So we should have a little understanding about what the pulmonary interstitium is made up of. So pulmonary interstitium is also called as a lung skeleton, and it is simply the connective tissue of the lung. It is a supporting framework, a collection of supporting tissue here we can see within the lung that includes the alveolar epithelium, pulmonary capillary endothelium, basement membrane, perivascular and perilymphatic tissue, divided into three zones. One is this is axial, here is the parenchymal, and this is your interlobar septum is the peripheral. So it is just a covering, it is a collection of supporting tissue covering the bronchovascular structure, secondary pulmonary lobule, alveoli, alveolar, and it is made up of connective tissue. Alright. So this is the geometry, this is how three-dimensional view of the connective tissue framework of the lungs look like, also called as a pulmonary interstitium, divided with the three zones depending on the area which is located. So this part, axial interstitium, encompasses or it makes a sheath around the peribronchovascular area, so it's called peribronchovascular interstitium. This is called this part is called your centrilobular interstitium. Within the lobular, this is called interlobular interstitium, and it is also makes a interlobular septa. All right. So this is here we can see the lung interstitium, and normally what happens, oxygen comes and CO2 is washed out. And here we can see, if you take a close look to this part to have a better understanding. So this is the lung interstitium, here we can see. This is your alveolar area inside the alveoli, and this is the blood vessel or capillary area. So what happens, all in the normal, if the interstitium is normal, thickened, or it's a normal thickness, all the oxygen that is coming to the alveoli that goes in the systemic circulation, and the CO2 goes out in the alveolar space to be washed out. But what happens when the interstitium is scarred? Here we can see this interstitium is thickened. All the oxygen that is coming in the alveoli, inside the alveoli, is not able to cross this barrier. Okay, So this is called diffusion limitation, means the diffusion of oxygen through this scarred or thickened interstitium is impaired or hampered. Likewise, the same happens with CO2. Here you can see CO2, all the CO2 is not getting washed out and not able to cross this thick scarred interstitium. It is causing the diffusion limitation of oxygen and CO2. All right. So, okay, so this is the area interstitium that is involved in this disease process. What happens? Normal physiology with ILD. In ILD, normal physiology we have just seen, all the oxygen that is coming to alveolar space gets saturated with the alveolar capillary blood. But in ILD, there is a ventilation provision mismatch and there is a diffusion limitation we have just discussed. Diffusion across alveolar capillary membrane is reduced. And what happens in VQ mismatch? In this condition, ventilation and blood flow are mismatched in the various region of lung. Because of the result that all gas transfer becomes insufficient. Here we can have, in this diagram, we can understand that what normal tidal volume is 500 ml and dead space is 150 ml. So we can calculate here alveolar ventilation. Total ventilation will be 7500 ml per minute, but alveolar ventilation will be here 5250. We can calculate in the next slide here. To calculate alveolar ventilation, tidal volume multiplied by respiratory rate, 500 minus 150, that is dead space volume, and it is coming around 5250 ml per minute or approximate 5 liter per minute. Similarly, you can calculate the pulmonary blood flow. Pulmonary blood flow is 100% of left ventricular volume. It's a complete of all the blood that is coming to the left ventricle is pumped. We know that from the pulmonary circulation, and that from there it gets oxygenated, it gets saturated in the lungs, and that goes in the systemic circulation. So entire cardiac output goes in each cycle to the lungs. And how does cardiac output is calculated? Stroke volume multiplied by heart rate. So stroke volume is 80 ml multiplied by 60, comes around 4800 ml per minute or approximately 5 liter per minute. So what does it mean? Alveolar ventilation is almost equal to your pulmonary blood flow. So all the blood, all the desaturated or deoxygenated blood that is coming from the heart gets saturated in the lungs, and then it go to the systemic circulation. All right, in the normal circumstances. And what is the contact time of capillary blood to the alveolar site for the gas exchange? All this event, all the whole blood that is coming to the pulmonary blood flow gets saturated with the oxygen in less than 1 second time or in the resting phase. But in case of exercises, in case of increased ventilated demand, this time can be as low as 0.25 second also. So this is the minimum time that is required for the almost complete blood to get saturated with oxygen in the pulmonary interstitium or alveolar capillary area. But what happens in case of the pulmonary alveolar barrier is there, or if the interstitium is thickened, this time will be there, but because of the thickened and scarred interstitium, the all oxygen will not be able to saturate the blood, because there will be, we have just seen diffusion limitation. The oxygen and the CO2 will not be able to cross the blood that barrier, that thickened interstitium, and that will lead to the ventilation provision mismatch and diffusion limitation. Coming to the etiology of ILD, interstitial lung disease, one is, we should all know, we know that etiology is known. In the second part, etiology is unknown. This is the very basic to understanding. What cause ILD? In some cases we know, in some cases we do not know. All right. So it could be smoking related, autoimmune, hypersensitive pneumonitis, medication induced, occupation related, idiopathic pulmonary fibrosis, and all of these disease spectrum, all of the cause, this you can see they share the common features of pulmonary fibrosis. All right. Here to understand dust, infection, radiation, autoimmune condition, other diseases like fumes, cigarette smoke, some drugs also, they all cause lung injury. And the lung injury is when there is a normal lung, if it is normal wound healing to abnormal wound healing. If there is normal wound healing, the wound healing is there, then the normal functioning lung tissue. And if there is abnormal wound healing, that may be, there is also some genetic predisposition to the ILD will be developing in those patients. So what does this mean? To understand the simple that all these etiologies, all the cause, our lung is constantly exposed to the various injurious stimuli, they cause damage to the lungs. And repair versus injury is continuous process in the entire pulmonary system. As long as there is normal wound healing, the lung will restore its normal function and the homeostasis will be maintained. But if there is a repetitive stimuli, there is a continuous injury, continuous stimulus, and lung is not able to heal it properly, and there is abnormal wound healing, in that situation disease processes start, and that leads to the lung fibrosis or development of ILD in due course of time. Coming to the pathogenesis of ILD, we have just discussed that exogenous or endogenous stimuli, that could be dust, fumes, cigarette smoke, autoimmune conditions, some drugs, infections, radiation, other causes, they will cause microscopic lung injury, and that is separated spatially and temporally in the timeline. That is a different, separated in the timeline, in the different time of the lung part. And what will happen if there is a wound healing? If wound healing remains intact, lung homeostasis will be maintained. But if wound healing is apparent, wound healing is not proper, wound healing is delayed, or it is not happening properly, so that will lead to the pulmonary fibrosis. There comes also a role of genetic predisposition and some autoimmune conditions. Here to understand what will happen, lung injury like inhaled agents, dust, bloodborne toxin or unknown antigens, they cause activation of macrophages in the alveoli. This alveoli macrophages will recruit the neutrophils, it will release the proteases, and also it will release the fibrogenic and chemotactic cytokines. They will stimulate the fibroblast, and this will lead to the fibrogenic and chemotactic cytokines, and this will cause hypertrophy and hyperplasia of type 2 pneumocytes, injury to type 1 pneumocyte, and ultimately in the later on there will be starting of fibrosis and pulmonary fibrosis develops. So, alveolar macrophage is the first cells that takes care of the any injury or injurious stimuli coming to the lungs. All right. Now, pathology is, we know that is the spectrum of disease from alveolitis to the frank fibrosis. Okay. What happens? What is the alveolitis to the frank fibrosis means? For example, interstitial lung disease is usually a chronic disease. All right. It happens in the timeline, and it takes time for lungs to develop pulmonary fibrosis. So, initially when there is alveolitis is there, when the initial injurious stimuli is there, so there is an initial inflammation, there is just a small alveolitis, and there is no frank fibrosis. Entire the second spectrum of the another side of the lung will be, there will be complete scarred or completely fibrotic lung, that we call idiopathic pulmonary fibrosis, typical of classically previously it was named for ILD. Okay. So, but fibrosis occurs in interstitium, and this is a frank fibrosis. It takes years, it takes sometimes years or even months to develop. All right. So, this fibrosis can be localized, can be segmental, lobar, or affect the entire of the lung. So, here we can see normal lung, but what happens in idiopathic pulmonary fibrosis? All the scar tissue, there is fibrosis tissue that is around the alveoli and causing the ventilation perfusion mismatch and diffusion limitation. So, alveolitis is initial phase, and what will happen in initial phase? It is an inflammatory phase. So, on CT and X-ray we can have GGOs, ground glass opacities, but when there will be frank fibrosis, we can get a honeycomb lung, or we call this as a end stage lung disease. Here all the lungs will be replaced by the honeycombing cystic pattern that we see in the frank fibrosis. To make it very simple, this is how the ILD develops. When there is injury and repair, it is both of them are maintained properly, normal lung homeostasis will be there, and you can see here the normal lung. But whenever injury is more and reparative mechanism fails to repair the lung, ILD or disease develop. Here we can see the ILD in form of cystic areas, honeycombing is developing. All right. So, it is all about the balance between injury and repair. All right. So, coming to the diagnostic approach to ILD, that we will discuss in the second part. Hope this will make things easier to understand.